The patient, 55 years old, presented with a complaint of mobility of tooth 31. Following clinical evaluation, it was determined that teeth 31 and 32 required extraction. In the area of teeth 41 and 42, the patient had crowns on implants, a composite restoration that had been functioning for approximately 30 years. Previously, an implant fracture had occurred in the region of tooth 41. I trimmed down the fractured neck and fabricated a composite crown for the patient using a healing abutment. Despite poor oral hygiene, both implants remained stable, although gingival looseness and inflammation were evident. After removing the old crown, we placed 2 PRO multi-units with a height of 0.5 millimeters. A temporary bridge would be fabricated and fixed onto these multi-units. In the region of tooth 32, we added a third implant and placed a PRO multi-unit on it. Due to insufficient bone, the implant was positioned at an angle toward tooth 33. Not an ideal position, but it was the only possible solution. We then proceeded with fabricating a 3-implant bridge. For fabrication of the temporary bridge, PRO multi-units were used together with standard screws, which dictated the resulting positioning of the screw access openings. You are now seeing a video of the technician modeling the crowns on the 3 implants. Thanks to the use of the trigony screw and the trigon screwdriver, it was possible to correct the direction of the access channel on implant 41. It was redirected to the lingual surface. On implant 32, such a maneuver was impossible. Shifting the access hole maximally toward the lingual surface would result in a defect of the incisal edge. All attempts by the technician to rotate the screw access channels toward the lingual side in exocad were unsuccessful. Therefore, the channel was shifted toward the buccal surface to bring the screw entrance as low as possible. We fabricated this version of the bridge. The patient was satisfied, but he was unhappy with the excessively light shade of the teeth. I therefore took the opportunity to redo the work using the Crest Fit multi-unit, which allowed significant improvement in aesthetics. Here you can see how the positioning of the screw channels changed. First option, the initial design stage of the bridge on Pro multi-units using standard screws. Work is possible only at a straight angle, which limits prosthetic possibilities. Second option, Pro multi-units with trigony screws. Angulation correction up to 35 degrees, expanded prosthetic flexibility. This corresponds to the first bridge where we were able to correct the access channel positioning for teeth 41 and 32. Third option, the final bridge, in position 32, the Pro multi-unit was replaced with Crest Fit, which greatly improved the final design. A clear demonstration of how Crest Fit provides maximum freedom in positioning screw channels. Again, let us compare the capabilities of each component. Here I show how easily the bridge can be removed when a polymer pin is placed inside the screw channel. First, a small opening is drilled and the pin is extracted with a fine burr, after which the channels are fully open. Using the back of the screwdriver, the pin is detached from the burr. Trigony screws are removed with the trigon screwdriver. The entire bridge removal process takes just a couple of minutes. Now I want to demonstrate the stability of the bridge. I intentionally left only one screw tightened to show that the bridge remains immobile. This result is achieved thanks to intraoral bonding of the sleeves. It provides maximum passivity of the restoration. I am now unscrewing a 3mm Pro multi-unit. It is easily identified by its color coding. The 3mm multi-unit has a pink plate. In its place, I install a Crest Fit of the same height and same color. Then a scan abutment is attached. All procedures are very simple. The triangular indexing of Crest Fit and the scan abutment orientation must always face the buccal side. I use the previous scan, cut out the required region corresponding to tooth 32, and perform an additional selective scan of that area. At this stage, I do not want to remove the Crest Fit multi-unit again and replace it with the Pro multi-unit, as unnecessary manipulation could traumatize the patient. Therefore, I take a diamond burr shaped like an olive and create a small recess in the bridge sleeve. Then I try in the Crest Fit multi-unit. Its height matches the previous multi-unit. After that, the bridge is placed back. The bridge is fixed with just 2 screws, exactly as it was initially with the temporary bridge. After fixation, we proceed to sealing the screw access channels. As usual, polymer pins are used. Due to the large diameter of the access holes, I preliminarily test the fit of the pins and trim them to the appropriate length outside the oral cavity. Then I fill the space with silicone-based material and perform polymerization. At the next visit, the corrected bridge is placed. This bridge includes 6 mm sleeves, an angled sleeve for the crest fit system, and 2 types of trigoni screws. Because silicone was used to seal the channels, we can easily reopen them. When necessary, a fine burr is used. The pins are lifted and removed. This takes only a few seconds. Then the screws are removed and the bridge is taken off. Now we can proceed with bonding the sleeves according to my protocol. A master sleeve is placed on tooth 42. It serves as a baseline support that ensures precise seating of the bridge during primary placement. We try in the bridge, verify that it seats securely on the multi-units, and begin bonding the sleeves. Adhesive is applied to the sleeves, the screws are already inside them, and the sleeves are inserted into the bridge. It is essential to perform these steps horizontally so the screws do not fall out of the sleeves. A crest fit sleeve can only be seated in one orientation. The flat surface must face strictly toward the buckle side. The bridge channel has the same flat surface, ensuring precise insertion and preventing rotation. We place the bridge, nothing interferes with the construction. We tighten the screws. Before the adhesive sets, the bridge remains slightly mobile, so it must be held manually. Polymerization is performed. After that, we check the occlusion. We unscrew the bridge to bond the master sleeve. The same rules apply. We return the structure for polymerization. We check the wash-through channels. For a patient with poor hygiene, this is especially important. In the region of teeth 32 and 33, there is inflammation and insufficient space for cleaning. The construction is removed for refinement. Excess material is removed, the bridge is tried in again, and the probe is used to check the hygiene space. The probe is still catching, adjustments continue. A green stone disc is used. Why choose a stone rather than a diamond disc for adjusting zirconia? When friction occurs, both surfaces heat up. Stone wears away quickly, and the detached particles reduce heat in the contact zone. Diamond instruments do not wear away. Both the burr and the zirconia heat up, which can damage the material. Thus, stone is preferable for zirconia finishing. We complete the surface refinement, polish, and finish. We proceed to final fixation. Once again, note, even when only one screw is tightened, the bridge does not move. This indicates a passive fit. A passive restoration does not create internal tensions, does not overload the implants, prevents screw loosening, and ensures long-term stability. This is achieved thanks to intraoral bonding of the sleeves. The gap between the crown and the canine is now ideal. The probe passes freely. Now the restoration can be definitively fixed. The trigon screwdriver is used, providing torque of up to 35 Newton-centimeters. We then seal the access channels with polymer pins, apply flowable composite, and thoroughly polymerize. Excess material is carefully removed. Final polishing is done with a gray rubber wheel. Its large diameter provides a very smooth and even surface. The work is complete.